it's coming, yeah.
Okay, then my talk is focused on the possibility of discontinued immunosuppression in lupus nephritis. Kidney disease is a frequent and severe complications of systemic lupus erythematosus. The clinical presentation can be variable, ranging from mild urine abnormalities to severe acute kidney injury or slow progression to end-stage renal disease. Kidney biopsy may show 6 different classes of lupus nephritis. Of these classes, the most important are class 3, class 4, and class 5. Class 3 is also called focal proliferative lupus nephritis and involves less than 50% of glomeruli with proliferative lesions. Class 4 is called diffuse proliferative lupus nephritis since it involves more than 50% of glomeruli. And class 5 is called membranous lupus nephritis, and it is characterized by an apparent thickening of glomerular basement membranes. From a clinical point of view, class 3 and class 4 lupus nephritis are characterized by a nephritic syndrome, meaning erythrocyturia, cell cast, hypertension, and tends to progressing to kidney function. Class 5 is rather characterized by nephrotic syndrome with proteinuria exceeding 3.5 grams per day associated with hypoalbuminemia and hypercholesterolemia. There are many prognostic factors in lupus nephritis, but let me focus on the 3 more important. First, renal flares. By reviewing our retrospective experience, we found that patients who never presented renal flares had excellent probabilities, even in the long term, of maintaining stable kidney function. Instead, patients with renal flares had only 40% probability of maintaining stable kidney function 20 years. Otherwise, they showed a doubling of their plasma creatinine. Dr. Moroni in our unit subdivided kidney flares into proteinuric flares and nephritic flares. Proteinuric flares are characterized by an increase in proteinuria of at least 2 grams per day, or a doubling in proteinuria if already it exceeds 3.5 grams per day. But in proteinuric flares, serum creatinine tended to maintain stable. Instead, in nephritic flares, there was a rapid increase in serum creatinine, exceeding 30% over the baseline, and it was usually associated with nephritic syndrome. Both proteinuric and nephritic flares were treated with methylprednisolone pulses and a short course of cyclophosphamide or azathioprine. And Dr. Moroni of our unit retrospectively reviewed the outcome and showed that the most proteinuric flares maintain a stable kidney function over the time, while patients with nephritic flares, although treated, showed doubling in serum creatinine in almost 80% of cases at 20 years. Another important prognostic factor is represented by a delay in starting treatment, and Dr. Forshu in Denmark showed that starting treatment more than 6 months after the clinical onset of nephritic symptoms were by the most important risk factor of end-stage renal disease in comparison with other prognostic factors. On the other hand, reaching complete remission after treatment was associated with a good prognosis in the long term, and this was demonstrated by a number of investigators. In our own experience, those patients who entered complete remission of proteinuria and stable kidney function had renal survival in 95% of cases at 20 years. Patients who entered only a partial remission had also a good outcome, with 93% renal survival at 20 years. And finally, patients who did not respond to treatment had renal survival at 20 years, only 43% of cases. Treatment of lupus nephritis is important. And in the last years, it was subdivided into an aggressive initial therapy in order to manage acute phases and prevent irreversible lesion, and in a maintenance therapy aimed to prevent renal flares and to protect from silent progression. And the aggressive therapy consisted in 3 intravenous methylprednisolone pulses, 1 gram each, followed by prednisone 1 milligram per kilogram in tapering doses, plus intermittent intravenous pulses of cyclophosphamide, 1 gram every 2 weeks, or oral cyclophosphamide, 2 to 3 milligrams per kilogram every day. And then after 2 to 3 months, patients were treated with maintenance therapy consisting of oral prednisone and azathioprine, or alternatively with intermittent pulses of cyclophosphamide. More recently, both rheumatologists and nephrologists agreed that many patients with class 3 or 4 do not have a presentation of severe symptoms, and therefore they suggested to start with the milder initial treatment. And they suggested, again, intravenous methylprednisolone pulses, but at doses of 0.5 grams, followed by lower doses of oral prednisone between 0.3 and 0.5 milligrams per kilogram per day, associated with intermittent low-dose intravenous cyclophosphamide, 500 milligrams every 2 weeks for 6 doses, or mycophenolate. Alternatively, a combination of prednisone with mycophenolate and the calcineurin inhibitors, particularly tacrolimus, was suggested. And for maintenance therapy, mycophenolate or azathioprine had to be associated with low dose of prednisone, less than 7.5 milligrams per day, or even no dose of prednisone. Hydroxychloroquine with regular ophthalmological monitoring was also suggested to prevent extrarenal flares. The refinement of therapy led to progressive improvement in the prognosis of patients with lupus nephritis. And single center series reported that renal survival at 20 years approached 90%. However, in spite of this consistent improvement in prognosis, proliferative lupus nephritis is still associated with a 6-fold decrease in mortality compared with general population, and lupus patients who develop end-stage renal dialysis have 26-fold excess in the risk of death. Thus, management of lupus nephritis remains unsatisfactory. And large part of this not satisfying results is due to the adverse events of the immunosuppressive drugs we are using in lupus nephritis. Let me remind you that glucocorticoids may be affected by obesity, diabetes, hypertension, dyslipidemia, and so on. Cyclophosphamide can cause bone marrow toxicity, gonadal toxicity. It is an oncogenic drug. It can cause infection. Calcineurin inhibitors can lead to nephrotoxicity, hypertension, diabetes, and many other complications. Azathioprine and mycophenolate also can have bone marrow toxicity, GI complications, can lead to liver toxicity and infection. And also rituximab can be affected by infusion reactions, it can be responsible for cytopenia and infection. So we may wonder whether it is possible to completely stop immunosuppressive therapy, at least in patients with lupus nephritis and stable kidney function. Many years ago, a voluntary attempt of adult treatment discontinuation was made in a few patients, but thus resulted in renal flares and rapid deterioration of kidney function. Some years later, we made another attempt, but we gradually reduced immunosuppression only in patients with stable remission, and after a median follow-up of 38 months, we did not see any flare in 13 or 14 patients who stopped immunosuppression. In one patient, a flare-up occurred 17 months after interruption of treatment, and this was characterized by nephrotic syndrome. The patient was treated again with a 6-month alternated corticosteroids and a cytotoxic drug, and again he entered complete remission. And following this experience, we decided to continue the attempt of withdrawing therapy in patients with unstable kidney function. And I'll show you the results in a couple of minutes. Just the time to present 2 other attempts to discontinue immunosuppression. Barber et al., in a retrospective study of 35 patients with stable kidney function, decided to interrupt therapy in 16 patients and to continue treatment in another 19 patients. And after mean follow-up of 10 years, the mean glomerular filtration rate was significantly higher in patients who stopped immunosuppression than in controls, whereas the SLEDAI scores, which is a score of symptoms of activity, was lower in patients who interrupted immunosuppression. At multivariate analysis, female gender, older age, SLEDAI score and diagnosis, and absence of azathioprine were predictive of successful withdrawal. Another attempt of steroid withdrawal was done in a small pilot randomized controlled trial of 15 patients. 8 patients were randomized to continue prednisone at a dose of 7.5 milligrams per day, and 7 stopped immunosuppression. After 3 years, major flares occurred in 50% of patients who continued treatment versus 14% of patients in the withdrawal group. And 3 participants in the continuation group also had minor flares. Coming back to our own experience, we tried to gradually stop immunosuppression in 73 patients. But 21 of these 73 patients developed flares during treatment reduction and had to continue immunosuppression. After a mean follow-up of 13 years, 20 of 21 patients were in complete remission and 1 was in partial remission. The other 52 patients could stop completely immunosuppression, and these patients have been subdivided in 2 groups. Group A was composed by 32 patients who never received immunosuppression after a median follow-up of 100 months. In Group B, 20 patients were connected, and all of them had at least 1 flare and had to be retreated, but 10 patients stopped against immunosuppression. After main follow-up of 24 years, 2 patients in Group A and 2 in Group B died. No patient in Group A and 2 in Group B developed renal insufficiency. Group A received longer treatment, a longer remission before withdrawal, and continued chloroquine. After these results, we feel that immunosuppressive therapy can be stopped, but only in selected patients with lupus nephritis. And we recommend that disease should be in complete remission for at least 3 years. Kidney biopsy may be useful, but it is not mandatory. Second, the longer is the duration of immunosuppression before withdrawal, the better will be the results. And we suggest waiting for at least 5 years of immunosuppression before considering complete discontinuation. Third, drugs should be tapered off very gradually under strict surveillance. The most delicate phase is represented by the reduction of treatment. And 4, hydroxychloroquine may help to prevent extrarenal flares. And one may wonder, what are the benefits of immunosuppression withdrawal? Let me point out that cardiovascular is a frequent complication in lupus nephritis. Both traditional and non-traditional risk factors may concur in its pathogenesis. The chronic use, in particular, of calcineurin inhibitors and glucocorticoids may aggravate the effects of the many risk factors. And possible mechanisms include hypertension, diabetes, dyslipidemia, thrombosis, and apophobinosis. And let me also point out that in patients with autoimmune disease, an increased risk of cardiovascular disease is associated with glucocorticoids even when given at low doses, less than 5 milligrams per day of prednisone. The benefits of immunosuppression withdrawal may be appreciated only in the long term. In a study of our group, we demonstrated that patients followed in me for 10 years after interrupting immunosuppression had significantly less frequent hypertension and lower cardiovascular events in comparison with patients who never stopped therapy. Another important consequence of systemic lupus erythematosus is the organ damage. Not only kidney, but many other organs and systems may be affected, including eyes, nervous system, chest, gastrointestinal system, etc. And data from large cohorts of lupus patients show that the damage may depend on different variables. But once again, hypertension and glucocorticoid use are among the strongest predictors of the acute organ damage. A retrospective clinical study showed that the damage accrual was significantly lower in lupus patients who interrupted steroid treatment in comparison with those who continued steroids. And extrarenal flares and organ damage were extremely rare in patients with lupus nephritis who stopped immunosuppression. Finally, malignancy. In lupus patients, there is an overall increased risk of cancer as compared with the general population. There is an increased risk for hematologic, lung, thyroid, liver, cervical, and vulvovaginal cancer, while there is a decreased risk of cancer for hormone-sensitive malignancies, including breast and prostate cancer. And the risk of cancer, is mediated by several variables, including viral infection, genetic factors, and other determinants, but an important role is played by immunosuppressive drugs. Concerning the role of immunosuppression, let me point out that cyclophosphamide is oncogenic, High dose and long-term use of cyclophosphamide may be associated with increased rates of bladder cancer, leukemia, lymphoma, and skin malignancy. Azathioprine is also oncogenic as it is incorporated into the DNA of the genome. And an increased risk of cancer for azathioprine was found in patients with inflammatory bowel disease. And the systemic review in multiple sclerosis hypothesizes that the risk of cancer from azathioprine may be related to a treatment duration of more than 10 years or cumulative doses of more than 600 grams. More uncertain is the role of mycophenolate, but the Food and Drug Administration warned against the increased risk of lymphoma and skin malignancy. And finally, calcineurin inhibitors can lead to an increased risk of cancer, which is dose and time dependent, and this effect is mainly related to the interference with immunosurveillance. The potential benefits of immunosuppression of withdrawal are demonstrated by the fact that even low doses of immunosuppression may reduce the risk of malignancies, but once again, when given for a long period of time, they can collaborate with the inflammatory and genetic environment present in lupus nephritis to induce several types of cancer. And therefore, this risk may be reduced by the withdrawal of immunosuppressive drugs. Therefore, in conclusions, dear colleagues, most of the serious complications of lupus nephritis originate in the early phases when the activity of the disease is particularly active and immunosuppressive treatment is aggressive. The persistent use of immunosuppressive therapy, even at low doses, may perpetuate and worsen the deleterious effects of these complications and can be responsible for frailty and poor quality of life. And in the long term, lupus nephritis usually shows a low activity that may facilitate a gradual withdrawal of immunosuppression in selected patients, and let me outline only selected patients. If made correctly, this maneuver can prevent the development of life-threatening and invalidating iatrogenic complications by preventing flares. Thank you for your attention. Is there any question? If not, we can proceed to the other lecture. It should be presented by Professor Mikhailovich from the Second University from Russia.